Welcome to This Explainer. We're diving straight into an anatomical and systemic journey. This is a rapid-fire clinical review, so let's get right into it. Here is our roadmap for today. We'll be hitting hip mechanics and arthropathy, moving down to knee joint pathologies, and wrapping up with systemic rheumatology and bone health. Starting off with Section 1, hip mechanics and arthroplasty. All right, first case. We've got a young male presenting with hip pain on weight bearing. You look at the x-ray, and there it is, a classic crossover sign. What is this radiographic clue pointing to? Is it A, medial pole osteoarthritis, B, femoral acetabular impingement, C, anterior pole OA, D, a healed SCFE, or E, AVN? If you guessed B, you nailed it. It's femoral acetabular impingement, or FAI. You see, there are two structural variations here. Cam impingement features extra bone at the femoral head-neck junction. It literally creates what we call a pistol grip deformity. Pincer impingement, on the other hand, is an acetabular overcoverage. The socket covers too much of the ball, and that's exactly what creates that distinct crossover or figure of 8 sign on the film. Moving on to surgical hardware. If you're placing a total hip arthroplasty implant, what must the minimum jump distance be to prevent dislocation? Are we talking A, double the diameter of the femur head, B, half, C, a quarter, D, 1/3, or E, 1/5? The correct answer here is B, half the diameter. Think of the jump distance as the literal lateral translation distance the center of the artificial femoral head has to travel before it pops completely out of the cup. Mathematically, it's just the radius, right? So, by utilizing a larger femoral head component, the surgeon inherently increases this half-diameter jump distance. This is absolutely crucial because it directly lowers the patient's long-term risk of a painful joint dislocation. Okay, another hardware question. What is the specific advantage of using a collarless, polished, tapered hip implant? Is it A, controlled subsidence and even compression? B, better anatomical fitting, C, better resilience, D, it's cheap, or E, none of the above? It's A, controlled subsidence. This is actually a brilliant piece of engineering. Because the stem lacks a proximal collar, it's designed to settle or subside just slightly over time. This utilizes the taper slip principle to convert harmful shear forces directly into protective compressive forces. It practically guarantees a continuous, tight load transfer between the cement and the mantle as the body changes. Let's talk pre-op. A 52-year-old female is up for a total hip replacement. Which antibiotic class is your absolute best bet to prevent a surgical site infection? A, vancomycin, B, tetracycline, C, clindamycin, D, a third-gen cephalosporin, or E, cefuroxime? And the answer is E. A second-generation cephalosporin, specifically cefuroxime, is your standard first-line prophylaxis. Why? Well, ortho-infections are typically driven by gram-positive staph. Cefuroxime gives you incredible bone penetration with narrow-spectrum anti-staphylococcal activity. You definitely want to avoid bringing out the big guns like vancomycin unless there's a severe allergy. And here's a quick example for you. Always make sure it's administered within 60 minutes of the surgical incision.
All right, traveling distally down the leg to Section 2, knee joint pathologies.
Picture this clinical scenario. A young patient comes in with severe knee pain. They feel like the joint is just giving way. They have an inability to bend it and a very specific difficulty descending stairs. What's causing this joint restriction? A, the ACL, B, the PCL, C, a meniscal tear, D, patellofemoral pain syndrome, or E, the MCL? The answer is D, patellofemoral pain syndrome. This case is a perfect illustration of the critical difference between a pain-induced pseudolock and a true mechanical block. In pseudolocking, severe pain or muscle guarding essentially mimics a joint block, and that classically flares up when the patient is walking downstairs. Contrast that with true locking, which is a sudden physical block, like a bucket handle meniscal tear that often abruptly clears if the patient just sort of jiggles the knee joint. Next up, we have a morbidly obese patient presenting with bilateral, deformed, and grossly swollen knees. You suspect an advanced mechanical burden. What is the single best first-line investigation here? A, bilateral X-ray underweight bearing, B, MRI, C, DEXA, D, CT, or E, ultrasound? It is A for sure. Standing weight-bearing plane radiographs are absolutely the gold standard. You have to evaluate the joint under an actual load to track the functional cartilage loss accurately. When you're analyzing these films, you're hunting for that classic radiographic quartet: joint space narrowing, subchondral sclerosis, subchondral cysts, and marginal osteophytes. Okay, time to zoom out to the microscopic level. Section 3, Systemic Rheumatology and Bone Health. We know that in rheumatoid arthritis, the body's immune system turns against itself. But which structures are primarily involved and directly degraded by this unchecked chronic inflammation? Is it A, the bony cortex, B, muscles, C, articular cartilage and bone, D, tendons, or E, ligaments? Now, hold that thought, because I want to test our knowledge on the flip side. Out of these options, A, increased bone formation and spurt formation, B, pannus formation, C, involucrum formation, or D, sequestrum formation. Which one denotes the hallmark pathological finding in osteoarthritis? Let's break both of these down side by side. For rheumatoid arthritis, the correct answer is C. RA targets the articular cartilage and bone using a highly aggressive fibrovascular tissue called a pannus that literally eats away at the joint. But for osteoarthritis, the answer is A. OA is primarily a mechanical wear and tear issue, so the body responds by trying to stabilize the joint, forming compensatory bony spurs or osteophytes to redistribute the heavy load. Now, imagine this. A middle-aged female with known rheumatoid arthritis suddenly develops an incredibly painful swelling at the back of her knee that extends right down into her calf. It perfectly mimics a deep vein thrombosis. What is the actual diagnosis? A, ruptured popliteal cyst, B, plantar tendon rupture, C, popliteal artery aneurysm, D, patellar dislocation, or E, vasculitis. The correct answer here is A. This is a classic ruptured Baker's cyst. You see, the excessive joint fluid produced by all that chronic RA inflammation drastically spikes the intra-articular pressure. This forces a valvular herniation of the posterior capsule. When that cyst acutely bursts into the calf, the ensuing intense pain and swelling create a condition appropriately known as pseudothrombophlebotitis. Let's look at another classic clinical footprint. A 45-year-old male wakes up with exquisite, severe pain in his right great toe. The MTP joint is incredibly tender, red, and erythematous. The trigger? A heavy night of binge drinking. What exactly triggered this localized fire? Is it A, OA, B, RA, C, gouty arthritis, D, psoriatic arthritis, or E, a fracture? And let's look at one final case before we reveal the biochemistry. A 49-year-old female comes in with bone pains and a lumbar compression fracture. But here's the catch. Her labs, calcium, phosphate, ALP, and PTH are all entirely normal. What metabolic bone disease causes devastating fractures but leaves the routine biochemistry completely untouched? A, Paget's, B, osteoporosis, C, osteopetrosis, D, osteotis fibrosa, or E, hyperparathyroidism. All right, tying it all together. That sudden toe pain post-drinking, that is C, gouty arthritis. Alcohol impairs uric acid excretion, leading to urate crystals depositing right in the joint. And that spinal fracture with perfectly normal labs, that's B, osteoporosis. It's a quantitative loss of bone mass, meaning the density drops, but the actual serum mineral levels stay perfectly normal. It really leaves us with a critical, lingering question. If the basic blood work looks perfectly fine, how early can we realistically detect these silent metabolic changes before a life-altering fracture even occurs?